Welcome to The Explainer. Today, we are diving deep into the new Ibero-American consensus on migraine treatment. Now, this is a pretty dense clinical document, but we're going to break it all down and turn it into a clear, actionable guide for you.
So, here's our game plan. We'll kick things off with a quick clinical overview, nail down the diagnostics, and then really get into the weeds on treatment, acute attacks, oral preventives, and the more advanced therapies. We'll wrap up by looking at those really tough, refractory cases.
All right, first up, a clinical overview. And really, let's start with why this consensus matters so much. Because, as we all know, a migraine is so much more than just a headache. It's a serious neurological disorder.
And the scale of this problem is, well, it's massive. The World Health Organization ranks migraine as the second greatest cause of disability among all neurological disorders. The only thing ahead of it? Stroke. So yeah, when you see a number like that, you really get why having a clear, effective, and standardized treatment plan is just so crucial. And even though it's the most common reason people show up at a neurology clinic, especially for women with a prevalence of 15 to 20%, here's the real problem the consensus points to. It's often underdiagnosed and, not treated properly. And that gap, that's exactly what these new guidelines are designed to close.
Okay, Section 2, the Diagnostic Foundation. Because you can't have a good treatment plan without a rock-solid diagnosis, right?
So everything starts here. Diagnosis is absolutely key. The consensus really hammers home the importance of using the official International Headache Society criteria. And why? Because you have to be able to clearly tell the difference between episodic migraine and chronic migraine. They are not the same, and getting this right completely changes the treatment path we're about to walk through.
All right, let's get into our first big deep dive, treating an acute migraine attack. The patient is in pain right now. The consensus is really clear here. They recommend what's called a stratified approach. Basically, you're not throwing the kitchen sink at it, you're tailoring the treatment to how bad the pain actually is. And this really lays out the core logic perfectly. It's a two-step process. Step 1. If the attack is mild to moderate, you start with non-specific drugs. Think NSAIDs. But, and this is a big but, if the attack is already moderate to severe, you don't waste time. You go straight to Step 2, migraine-specific drugs like triptans. The goal is faster, more effective relief. Okay, so let's really dig into this table of non-specific options for those milder attacks. First up, you've got acetaminophen. The dose is 325 to 1,000 milligrams, but you absolutely can't go over 4 grams in 24 hours. The consensus highlights this one specifically for mild attacks, and importantly, it's compatible with pregnancy. Then you have ibuprofen, your classic go-to NSAID. We're talking 400 to 800 milligrams with a max daily dose of 2,400 milligrams. This is your workhorse for mild to moderate pain. And finally, naproxen. What's interesting here is the wider dose range, all the way up to 1,500 milligrams. The guidelines point to this one for attacks that tend to last longer. Think menstrual migraines, for example. But what happens when the pain is more severe, or those NSAIDs just aren't cutting it? Well, the guidelines are crystal clear. You move up to triptans. They are the first-line specific treatment. Now, this is super important because the consensus stresses that you can't just pick any triptan. They're not all the same. This table gives us a fantastic clinical ranking based on the situation. So let's say you need fast relief for a rapid onset attack. Your top choice is sumatriptan, with rizatriptan as a close second. On the other hand, if you're dealing with a long-duration migraine, maybe one that's hormonally driven, you want something with a longer half-life. That's where frovatriptan comes in as the top pick, with naratriptan as the next best option. And what about tolerance? For patients who are sensitive to side effects, the guidelines recommend starting with naratriptan or frovatriptan as the alternative.
Okay, so now we're in the emergency department. The game changes because we need faster action, so we're looking at IV options. The go-to protocol starts with ketorolac, that's an NSAID. Give it IV at 15 to 30 milligrams. Now you'll often pair that with 10 milligrams of IV metoclopramide. This is great because it not only tackles the nausea and vomiting, but it actually helps the headache too. But if the attack is really severe, and maybe they haven't used a triptan yet, the powerhouse option is 6 milligrams of subcutaneous sumatriptan. That's going to give you some really rapid relief.
All right, so we've handled the acute attack. Now the conversation shifts to the long game, prevention. This brings up a really important question. Who actually needs to be on a daily preventative treatment?
So who does need preventative therapy? Let's take a look at the specific criteria laid out in the consensus.
And the answer is really nuanced. It's not just about counting the number of headache days.
Sure, having 4 more attacks a month is a big one, but you also have to consider prevention if the acute treatments just aren't working well enough, or if someone is using those acute meds more than twice a week, because that puts them at risk for medication overuse headache. And then there are special cases, like attacks with a prolonged or scary aura, or frankly if the attacks are just causing a major disability in someone's life.
Okay, so once you decide to start a preventative, which one do you choose? This is where the guidelines get really smart, focusing on tailoring the drug to the individual. Propranolol, a beta blocker, is listed as the go-to first choice for both episodic and chronic migraine, but from there, you personalize. Got a patient with comorbid depression or sleep issues? Amitriptyline is the way to go. It helps both problems. What about a patient who also has obesity? Well, topiramate is a great choice there, since weight loss can be a side effect. And for someone who has a mood disorder like bipolar, sodium dalproate is perfect because it works as both a mood stabilizer and a migraine preventative.
But what about the patients who've tried these oral options and they're just not getting the relief they need? Well, for those more complex cases, the consensus moves on to advanced preventative therapies, specifically injectables.
And here we've got two main players, botulinum toxin A, yep, that's Botox, and the newer CGRP monoclonal antibodies. I love this slide because it shows how they work in different but really complementary ways. Think of it like this. Botox works on the presynaptic side. It stops the nerve from even releasing the pain signals like CGRP in the first place. The CGRP antibodies, on the other hand, work on the postsynaptic side. They act like a blocker, preventing that CGRP signal from ever being received. So one stops the message from being sent, and the other stops it from being heard.
The consensus gives us a great overview of the 4 main CGRP antibodies available. Let's break them down. First, you have erenezumab. What makes it unique is that it targets the CGRP receptor, not the molecule itself. It's a subcutaneous shot you take every 4 weeks. The other 3, fremonizumab, galcanezumab, and eptinezumab, all target the CGRP ligand, the molecule. This gives us options. Fremonizumab and galcanezumab are both subcutaneous, but fremonizumab offers flexible dosing, either every 4 or 12 weeks. Galcanezumab is every 4 weeks. And then there's eptinezumab, which is different because it's given as an IV infusion every 12 weeks, which can be a great option for some patients. And this is a really interesting point for those super refractory patients. The guidelines now officially support the idea of dual therapy. So if a patient has tried both Botox and a CGRP antibody and only gotten a partial response from each, you can actually combine them. The idea is to leverage those 2 different mechanisms of action we just talked about to hopefully get a much better outcome.
So that brings us to our final section. What do you do for the patients who just don't respond to any of this? We're talking about refractory chronic migraine, the toughest cases of all.
At this point, the consensus suggests we need to start thinking outside the standard pharmaceutical box. First and foremost, it calls for interdisciplinary management, bringing in multiple specialists, and it highlights some specific non-pharmacological options like the ketogenic diet. Then, for very severe cases, we're looking at hospital-based treatments like infusions of lidocaine or even ketamine. Of course, these are options that have to be done under very careful specialist supervision.
So where does this all leave us? Well, the consensus wraps up by looking to the future, and it's a pretty exciting one. They envision a time where treatment selection won't just be stratified based on symptoms, but will be truly personalized, maybe using AI models or biomarkers to predict, right from the start, which treatment will work for which person. And that leaves us with a really big question to think about. As we push towards this era of personalized medicine, how is this combination of AI and biomarkers going to completely change how we treat not just migraine, but all complex neurological disorders? Are we on the verge of a time when a simple test can finally tell us exactly how to treat a patient, getting it right the very first time? Thanks for watching.